In this video, you'll explore 5 carefully structured MCQs. The correct answer and the 4 incorrect ones are each thoroughly explained for real conceptual understanding. Let's begin.
Many psychiatric medications have a lipophilic nature. Thus, it follows that A. Taking them with food improves their absorption via the digestive system. B. They show greater resistance to metabolism in the liver. C. They attach easily to free fatty acids in circulation. D. They pass easily from the bloodstream to the brain. E. It is less probable that they contain active metabolites.
The proper choice is D. Most of the drugs are absorbed in the proximal small intestine. Proper gastric emptying improves medication absorption. Drugs with low pH are better absorbed in the stomach, but most absorption is passive and controlled by lipid solubility. No absorption improves with food in the stomach. Psychotropics are transported by plasma albumin and alpha-1 acid glycoprotein, not free fatty acids. Starting in the small intestine, drug metabolism is mostly done in the liver with minor kidney and lung involvement. Lipophilia helps renal tubules reabsorb lipophilic medications after passing through biological membranes like the renal glomeruli. Drugs can only be removed by the kidneys after becoming hydrophilic metabolites. Functional barriers make the CNS and CSF hard to reach. Brain capillary endothelium and pericapillary glial cells form the blood-brain barrier. Lipid solubility and transcellular transport channels affect central nervous system absorption of non-ionized and unbound drugs. A lipophilic medication is more likely to pass the blood-brain barrier.
The 56-year-old female patient has been complaining of nausea, vomiting, myalgia, lethargy, headache, and fever for the past 3 days. Although she denies experiencing dysuria or abdominal pain, she does mention a cough with little hemoptysis. She returned from a month-long missionary trip to a small Liberian village around 1 week ago. The yellow fever vaccine, among others, had been administered to her before her trip. Her malaria prophylaxis was taken as instructed. She appears to be in minor respiratory distress, has a rapid heart rate, and is tachypneic. There are no other rashes or lymphadenopathy, however, she does have generalized petechiae. Which pathogen is most likely to be present? A. Plasmodium malariae, B. Salmonella typhi, C. Influenza virus, D. Ebola virus, E. Mycobacterium tuberculosis.
The correct response is D. The patient is experiencing flu-like symptoms accompanied by petechiae and hemoptysis, suggesting a predisposition toward hemorrhage. Her symptoms, history of travel to a region of Africa where the Ebola virus is known to be circulating, and other factors point to a hemorrhagic fever as the most probable diagnosis. Yellow fever, dengue fever, Lassa fever, Marburg, and hantavirus are among the other hemorrhagic fever syndromes. Infection of the vascular bed causes microvascular damage, alterations in vascular permeability, and organ dysfunction as part of the pathophysiology of this disease. Taking her malaria prophylaxis reduces the likelihood of a diagnosis of malaria, which is caused by Plasmodium species and can manifest similarly. The absence of abdominal pain, petechiae, and hemoptysis rule out Salmonella typhi and Salmonella paratyphi, the most prevalent causes of typhoid fever in returning travelers. While influenza is a year-round prevalent in the tropics, cases of hemorrhagic tendencies are rare. Acute hemorrhagic fever is not a common symptom of tuberculosis, which often manifests at a subacute stage.
A 79-year-old resident of a nursing home arrives with fever, confusion, coughing up sputum, and difficulty breathing. His medical history includes diabetes, high blood pressure, and dementia. Current medications are insulin, metoprolol, and aspirin. He has allergies to eggs, sulfa drugs, and ACE inhibitors. He is diagnosed with healthcare-associated pneumonia affecting the left lower lung. Upon admission, treatment begins with linezolid, meropenem, and levofloxacin, leading to significant clinical improvement. By day 5, he is ready for discharge. Cultures from sputum and blood identify Klebsiella pneumoniae, which shows resistance to ampicillin and cefazolin, but remains sensitive to ceftriaxone, piperacillin tazobactam, meropenem, ciprofloxacin, and trimethoprim sulfamethoxazole. Which of the following is the appropriate antibiotic choice for discharge? A. Continue the same intravenous antibiotics on discharge. B. Switch to oral trimethoprim sulfamethoxazole. C. Start oral amoxicillin. D. Start oral ciprofloxacin. E. Continue intravenous piperacillin tazobactam on discharge.
The correct answer is D. The patient initially received broad-spectrum antibiotics for healthcare-associated pneumonia, but culture results showed a less resistant organism. Since he improved and can take oral medication, narrowing therapy to oral ciprofloxacin is appropriate. Continuing all intravenous antibiotics increases risks without benefit. De-escalation is key to antimicrobial stewardship, reducing toxicity and resistance. Trimethoprim sulfamethoxazole is contraindicated due to sulfa allergy, and ampicillin or cefazolin are ineffective against Klebsiella strains.
A 35-year-old previously healthy man gets purulent sputum, causing coughing for days. In ER, he is found to be lethargic. The pulse is 110, temperature 39 degrees Celsius or 102 degrees Fahrenheit, and blood pressure 100/70 millimeters of mercury. Rales and dullness found on percussion at left lung. No rash. Supine neck flexion spontaneously flexes hip and knee. Neurologic examination is normal. No papilledema. Out of 8,000 leukocytes per microliter in CSF, 90% are polymorphonuclear. With 80 milligrams per deciliter peripheral glucose, glucose is 30 milligrams per deciliter. High 200 milligrams per deciliter CSF protein. Awaiting CSF gram stain. Which is the right treatment? A. For herpes simplex encephalitis, start acyclovir. B. Prior to commencing treatment, get an MRI scan. C. Start dexamethasone followed by ceftriaxone and vancomycin for pneumococcal meningitis. D. Start ceftriaxone, vancomycin, and ampicillin to cover both pneumococci and listeria. E. Start high-dose penicillin for meningococcal meningitis.
Choice C is correct. The CSF profile, meningeal irritation, and positive Brudzinski sign suggest acute bacterial meningitis. The patient probably has pneumonia. The combination suggests pneumococcal infection. Before susceptibility data, ceftriaxone and vancomycin are recommended due to beta-lactam resistance. A brief course of dexamethasone before or with the first antibiotic dosage is advised for suspected bacterial meningitis. Dexamethasone reduces meningitis neurological sequelae and death. Herpes simplex encephalitis, CSF is lymphocytic and glucose normal. Listeria monocytogenes, meningitis affects immunocompromised people, elderly and drunken people. Nasopharynx entry Neisseria meningititis is the second most prevalent cause of bacterial meningitis, but seldom causes pneumonia. Penicillin G kills meningococcus, but empiric therapy should cover all suspected bacteria until gram stain and culture results are available. Treatment should not be postponed for CT or MRI scans because the patient has no papilledema or focal neurologic symptoms.
A man in his 60s presents with a history of worsening low back pain that has occurred within the last 3 weeks. At the start of the pain, he had felt a little fever. Acute pyelonephritis was his diagnosis and was treated 4 months ago. During the physical examination, the doctor noticed paraspinal muscle spasm and tenderness over the L2-3 vertebra. There is an increased C-reactive protein level and an erythrocyte sedimentation rate of 80 millimeters per hour, according to the laboratory results. Out of the following assertions, which one is true?
Vertebral involvement in adult hematogenous osteomyelitis is uncommon. Soft tissue was probably the first target of the infection. Most patients will have positive blood cultures after this process. An MRI scan characterizes the process with sensitivity and specificity. In cases of osteomyelitis, surgical intervention is required.
The answer is D. The presentation strongly suggests vertebral osteomyelitis. MRI is sensitive and specific for the diagnosis of vertebral osteomyelitis and is the diagnostic procedure of choice. MRI will reveal the extent of contiguous disc and soft tissue involvement and will help assess for pending neurological compromise. The vertebrae are a common site for hematogenous osteomyelitis. Prior UTI is often the primary mechanism for bacteremia and vertebral seeding. Blood cultures at the time of presentation are positive in fewer than half of all cases. Treatment requires 6 to 8 weeks of antibiotics, but surgery is rarely required for cure.